The relapse needs to be differentiated from the slips. The slips is occasional use of tobacco and a person again becomes tobacco free. So it's not like this that a person who is taking tobacco, who has quitted tobacco, takes it 2-3 times in a day, every day. That person will not be categorized as a slip in tobacco use or in quitting tobacco. This person therefore has relapsed. But somebody comes after 6 months and he says, doctor, I have maybe one or twice, I have puffed cigarette or I have taken a small bite on tobacco. Fine, but he has otherwise stayed quit. I asked my criteria that if somebody has used tobacco at all in the last 30 days, he is a successful quitter. And the relapse increases with the passage of time. That one has to remember. That is why a longer term follow-up is necessary. There are two precipitating factors. The factor of excessive joy, people who get into celebration in marriage, festivities, promotion, etc., new arrival in the family, and you get back to tobacco use. Or a person suffers from excessive grief of illness, the loss of job, loss of dear ones in the family, and one gets into the grief or a transfer to a lonely place. The people start tobacco use again. So you need to forewarn them during the counseling that, look, you have agreed to quit and stay quit throughout the life. These are two factors, or these are the situations where you can relapse. Better stay quit, better stay warned and aware. And if you quit, if you relapse somehow, you better get back to quitting again. That is very important. Come back to us. Don't worry about it that you relapsed. More important is that you quit again and again become a tobacco-free person. This is the whole list of the withdrawal symptoms. And withdrawal symptoms are from cravings, irritation, inability to concentrate or recall. Constipation is a major problem in most of the Indians. That is why they take tobacco in the morning, first thing in the morning. Sleep disturbances do occur. Some people get headache, or they may have fatigue or lethargy, or sometimes the coughing increases because now that tar is not depositing in the bronchial walls, it is getting removed, so it is causing irritation and that causes coughing. So when I talk about withdrawal symptoms to the people, to tell them that, look, when you are quitting, these physical ailments you may suffer. Treatment of this is easy. It requires just some symptomatic treatment with the simpler medicines, but also remember that this is the manifestation of nicotine deficiency. Remember that not everybody suffers from all these symptoms. Also remember that these are transient only. Majority of these will last for a week or two, rarely over a month's time. And then the management which requires by explaining them their basis and treating this symptomatically. Use of pharmacotherapy for cessation reduces their recurrence. Many people are not taking medicines which are given to them along with counseling. They consider that tobacco use is just a habit. It doesn't require medical treatment. But remember that medical treatment is important. It's like treating the emergency. Emergency is what? Withdrawal symptoms. That is why it's very important to emphasize that use pharmacotherapy for cessation. So we'll talk about pharmacotherapy, which is very simple actually, and it's not as complex as many other things that we learn in our career treating several illnesses. First is nicotine replacement therapy. In India, nicotine replacement therapy is available as nicotine gum, nicotine lozenges, or nicotine patch. We still don't have spray or inhalers. The main primary medicine we have available is bupropion sustained release in two forms. Varenicline, which is again an antidepressant, was available as a product but has been withdrawn recently because largely it was being provided by Pfizer. I am told that it's available online, but whenever I tried online availability, that also is not available for last 6 to 8 months. So I consider we have lost one good drug, but we still have the hope and the support of these two drugs, which are very helpful. And some people may get benefit of use of nortriptyline. I am not aware of the utility of clonidine maintained in the literature. This is more used by the cardiologists, so maybe it can be asked as to how do they use clonidine, and one may use. But I consider I am happy using NRT and bupropion in most of my patients. The cost of treatment is between 15 to 25,000 at all for tobacco cessation if somebody does it sincerely for at least 3 to 6 months time. And this cost is much less than the cost of treating a tobacco-related illness. That one has to emphasize. The economics of tobacco use, the economics of treating a tobacco illness needs to be told as well, because not many people would like to invest in tobacco cessation. It's time that they start doing it. So nicotine replacement therapy, as I told you, is available on 3 types. And currently, the gum and lozenges are available in 2 and 4 milligram. I teach patients how can they titrate and use this as necessary. They need to suck or chew the nicotine gum slowly, and then they have to park or spit it. That is, they can, if the more than half of the portion is remaining, that means you can use it later. Instead of spitting it, park it between the gum and the cheek. That is what one can do. And that is if it's not there, or one uses the entire 2 milligram, or only a small part is left, one can spit it. Most important step in nicotine replacement therapy when you're using gum and lozenges is that stay nothing by mouth for next 15 minutes. The release of nicotine in the drug form or in the pure form and its absorption from submucosal venous plexus takes time. And if one takes some kind of liquid, the liberated nicotine from gum or lozenge will get wiped off and will go in the stomach and will lose its efficacy. So it's most important instruction that when you use gum or lozenges, once you have got the satisfaction of tobacco use on chewing or sucking it, stay nothing by mouth for next 15 minutes. Don't take water even. That is very important. Now, when when NRT is not to be used, it should not be used within the 6 weeks of an acute myocardial infarction or stroke. It is an absolute no here, because nicotine causes vasoconstriction and can worsen the clinical situation which is already existing. It is not to be used by the pregnant women and during lactation. It can be used with caution in some children below or in adolescents below 18 years of life, and very rarely for uncontrolled hypertension. I prefer not to use it. I would rather emphasize on counseling and prolong my time of counseling, tell patient as to what skills he can learn to stay tobacco free and without use of pharmacotherapy. Bupropion needs an doctor's prescription. It's an antidepressant group of drug. It's available in 2 forms, the sustained release form, which is to be given in 2 doses, or extra large single dose as we give it. Bupropion SR, when it is used, it is to be given 150 milligram once in a day for the first week, and thereafter we increase it to twice a day doses, and both are given after meals. Bupropion XL is to be used 150 milligram for first 10 days, and thereafter 300 milligram at bedtime every day along after meals. Use it for at least 8 weeks or extend the use to another 4 weeks. It is not to be used in alcoholics, those who are having liver failure due to cirrhosis, or there is a history of convulsive seizures or following head injuries. It is not to be used again for pregnant women, for lactational women, mothers, and for adolescents below 18 years of age. Very simple drug, doesn't have many side effects, very effective, but effect takes time, about a week or 10 days for the effect to begin or for the action to come in. And that is where one has to be patient, because once this drug starts having its effect, the need for NRT will reduce for the person. And then he will not have to take nicotine, gum or lozenges, which initially I tell them that you use it as much as required. Don't go back to tobacco use, because most of the people will take nicotine gum or lozenges without proper instruction, or they will take it only 2 to 3 times, and in between they also use tobacco. And that's why they fail. They will never be able to quit. They will be able to reduce tobacco use for some time, but they will not be able to quit unless a person who is an addict to tobacco takes nicotine replacement therapy for 8 to 10 to 12 times a day. The toxic dose of nicotine is 40 milligrams. So it's a pretty safe drug in somebody who doesn't have cardiac ailments. Varenicline, as I told you, it's not available globally, but this is the most effective drug. It is 2.5 times more used. It comes in the blister form and used as the drug which is to be used in the incremental form, 0.5 milligram 3 days, twice a day for next 4 days, and then 1 milligram for next 12 weeks. So I think this is important. One has to be careful not to use it in patients who are suffering from psychiatric illnesses or those who are having renal failure or chronic kidney disease. Again, it is contraindicated in pregnant women, in lactating mothers, and adolescents below 18 years of life. So these are different variations in which one can use pharmacotherapy. You may use NRT alone. You may use it with or without patch. Patches are to be used for somebody who is unable to take the medicine orally, or patches are to be used when the profession is such that you have to speak a lot. You can't take the nicotine replacement therapy very frequently. That's where the patch is helpful. Patch is costly. Patch requires certain instructions to be followed. It has to be put on the non-hairy area of the body. Some people get reactions to the patch in the allergic form, and therefore not many patients accept the nicotine patch. The nicotine replacement therapy in bupropion is the workhorse for me for all tobacco cessation practice that I do. Most of the people, I prefer to put them on both the drugs, telling them how to use these drugs, when their effect will start coming, when do they have to wean off NRT, and when do they have to wean off bupropion. People can use bupropion alone when NRT cannot be used. People can use NRT when bupropion cannot be used. Varenicline as a standalone drug is effective. Hopefully it becomes available again. It is the succinate component in it which has been found to be harmful, and that's why they are trying to formulate varenicline with another salt. That's why it's been withdrawn globally as far as I know. NRT can also be used with varenicline where the intensity of withdrawal symptoms is such that people require support with the nicotine replacement therapy. So these are the different combinations, permutations that one can use in pharmacotherapy. But I consider any experienced doctor will be able to give pharmacotherapy effectively if you know this much about the pharmacotherapy of tobacco cessation. Supportive environment is must. You need to have the people, family, friends, and peer who are positive in their attitude and approach, who will not kind of trying to sort of give you a look that you are the person who is almost like a criminal who is using tobacco, not looking into our sensitivities, our needs, not taking our care. We require people who are supportive, who will say that, okay, quitting is possible. You will be able to quit successfully. We are there for you whenever you have withdrawal symptoms. Come to us if you can't control it yourself. We will help you as much as possible. Their availability is very important. So I always tell people, who are the people to whom you can approach unhesitatingly? Have a list of these people. Tell them that you are quitting tobacco, and you will give them a call if required whenever you are suffering from craving, restlessness, irritability. If this cannot be controlled with your pharmacotherapy. I think this supportive system is very, very helpful for successful quitting. These are 7 Ds, or the skills that I was talking about. Drinking a lot of water when you quitted tobacco helps a lot. Dryness of mouth is a problem. Every time if one takes few sips of water, your craving goes off. That helps. Diversionary tactics through deep breathing is one exercise which can help people. Focusing on breathing is part inherent to us, as through the pranayam we have learned through our yoga system learnings that you can control your breathing. You should control your breathing, do some exercises like Kapal Bhati, Anulom Vilom, etc. But in tobacco cessation, it's primarily to divert your attention from tobacco use or distract your use from the triggers that you may be having at that time. As much as you delay the tobacco use, then your quitting becomes more successful. So 4 Ds are very important. Drink water, deep breathing, distract, to delay the use of tobacco for as long as you can. The Abstinence of tobacco also brings about improvement in the diet. But those who are taking tobacco, or people take tobacco because diet is not available to them. People like police wallahs, the drivers, the nurses, the sanitary worker, the workers at the construction site, they may not get the food in time. That's why they still their appetite with the tobacco use. So telling them eat at right times. Don't postpone your lunch. Don't postpone your dinner. Eat when you are hungry. Leave the person off tobacco. It's very important that after the initial counseling, the people discuss their smaller problems, shorter of the issues. They have somebody as a buddy system, as a spouse or a quit coach who can help them stay quit. Then, as I told you, pharmacotherapy is very important. So, 70 methodology. I have drawn this slide from our co-partners. I Can Care in tobacco cessation, a good job. Course which one can attend to get a diploma in tobacco cessation. I will strongly recommend that you go for it. See for their website, I Can Care, and they also have an app which you can use for the tobacco using patients. So there's a lot that I have learned. I have also attended this course. I consider this a good course, but I'm not advertising. I'm just saying that if you want to be certified as a tobacco cessation specialist, this is one portal we have currently in the country, which is university recognized. 7 days is what is most important in letting a person learn the skills. There are so many other skills. Getting engaged into physical activity, getting engaged into the things that you like, listening to the music, dancing, gardening, going for a walk. All these things can be done to distract one from the tobacco use. These are the determinants in successful quitting. These are most important. If somebody is doing all this, he cannot fail after quitting successful. Sorry. So if a patient is in preparation phase of the cycle of Proshasta cycle of change, then he is the best person who will quit successfully. If the person has an access to quit portal in form of tobacco cessation clinic or quit line, they will quit again successfully. People who don't change their quit date, they will quit successfully. Those who have optimally implemented the skills to stay quit, they will stay quit successfully. Those who have managed to live now in tobacco-free environment, they will stay quit. Those who uses pharmacotherapy optimally, they will stay quit. Those who follow up regularly, they will stay quit. And those who have social support. So these determinants are very important. And if somebody has all these favorable determinants, I think quitting becomes successful. I will take up this case here for discussion, that this gentleman RB, who is 56 years, is a male smoker. He was operated for peripheral vascular disease by bilateral aortofemoral bypass a year ago. This gentleman could not stop smoking hookah post-operatively. The plastic surgeon who operated him last week for a non-healing ulcer in the right leg was referred for cessation treatment to me. On counseling, first he agreed that I will quit as you are telling, and I will stay quit. I said, you have hookah in the house, discard that hookah. So he said, no, my wife smokes. Socially, we cannot be without hookah in our house, because otherwise we'll be outcast from the society. So I will not be able to discard hookah. But when his granddaughter, who was standing by that side, by the bedside, said that he will not quit, he got very upset and told me that whether I like it or not, he won't quit, even if he dies, because of the failure to quit. So I think it's very important. And we see here a scenario. So my first question to you will be, you can put it on the chat. What else do you need to know in the history of tobacco use of this patient? I consider Dr. Ritika, you can perhaps see the response of the people, which I can't see right now.
Yes,
So this
doctor,
is
I'm
the
doing, I'm
first
just
question.
mentioning everything
And I
required.
hope people are responding to this question as to what will they do or what will they ask in the history of tobacco use. Can you tell me some of the answers?
Okay. Doctor has asked question regarding this particular case, where he wants to know what else you need to know in the history of tobacco use by this patient. Please write it on the chat box. We'll be taking the answers from there. They have already given their personal questions, doctor. The answers are not mentioned yet. We'll be
Okay.
giving them a second or so.
Right.
Okay. The duration,
Can you,
use,
yeah,
yes.
can
Dr.
they
Purnima.
categorize this patient by using the theory of change or Proshasa cycle of change? What category this patient is?
Dr. Purnima has written the duration and daily use.
The duration of use is very important. So also the whether he is just a smoker of hookah or does he use
Right.
chewable
Dr.
tobacco as
Sashopan.
well. We need
Right.
to know. Yeah. We also need to know whether he has quitted in the past any time and whether he quitted when he had major surgery a year ago, whether the doctor told him about quitting. So those are some of the points in the history of tobacco use that we need to take.
And previously, how did he try to quit?
Yes, if he at all quitted. This patient did not quit at all. He said, I did
Okay.
not quit. I could not quit last time also following surgery. That's why he developed an ulcer actually.
Okay. What specific diet we should prescribe? These are the questions
What
other than the
specific
question.
diet?
We could
More
prescribe.
than the type of diet, it is the, yeah, more than the type of diet, it is the times when you should not be staying hungry. That is very important. Take food in time, whether it's breakfast, lunch, or dinner. You should not be hungry because people who quit tobacco, they feel hunger as one of the, uh, you can say, sequelae. And some people also gain some body weight, but gaining body weight should not be their bigger concern. Their bigger concern should be to stay tobacco free. So I think that is very important nutritionally. But one can also consider some nutritional supplements. I would say multivitamins, vitamin B12, folic acid, some mineral containing vitamins. I think those are some of the things which are useful for a person to recuperate from the side effects or the harms of tobacco. Right. So have they categorized for this patient as to where did they put him in? I'll just give the tips like pre-contemplation, contemplation, preparation phase, action phase, or maintenance. The correct answer here is that this patient is in pre-contemplation. He doesn't want to
Okay.
quit. How will you counsel such a patient? Person who is not willing to quit. We discussed this.
Assure
If
him
the
that
5 A's is not
we are with them in quitting tobacco and follow all the steps which have been told. 5
right,
hours.
5 hours. That is very important. Can somebody
And the
recall all
A's.
those 5 hours?
Right.
Yeah. Or two A's and R is not the solution. Actually, 2 A's and R is for those who do not wish to deliver tobacco cessation after ask and advise. But 5 hours is relevance of tobacco use and quitting, the rewards, the risks which are there of tobacco use, the rewards of benefits of quitting, the roadblock that person has, and then the need for reputation. So that is what one has to do. One has to keep the door open for such patients that, okay, if you are not willing to quit now, that is what I did. I said, you don't want to quit, don't get upset. Don't just get annoyed with your granddaughter who is telling the truth about you. But if you want to quit, I will always be available to you. Quitting will help you in healing of the ulcer. The skin graft you have will take much better. Otherwise, the graft may get discarded again. So those are some of the things I told him, as well as keeping my door open for him anytime he wants to quit. The next question is that he is not adamant on quitting. What will you say to him? I have already answered this question.
Right.
And last question is, will you prefer to give him NRT and or bupropion? What will you give to this person?
What
Nicotine
particular
replacement
drug can we
therapy?
go forward with?
Mm-hmm. Has anybody responded to what drug they will give or a
For second
combination of?
doctor, they'll be, yes, bupropion, and one has written NTR. So both the answers are there,
NRT,
NRT and,
nicotine replacement.
right.
NRT preferably should not be given. This person has a peripheral vascular disease and has had bilateral aortofemoral bypass. So his blood supply is already in jeopardy. I'll prefer not to give him NRT. And here, perhaps this person doesn't even want to quit. So I'll rather leave him with bupropion and let the effect of bupropion come, which is by nicotine substitution at the receptor site. So his need for nicotine may become less, and his follow-up is more important again, if he's willing to quit. That I consider, and that is doable because there is evidence that if more than one person is giving counseling or supporting these patients through the multiple sessions. So in this case, the cardiovascular surgeon who has operated him for the bypass, the plastic surgeon who has done the surgery on him, the diabetologist who is treating his diabetes, they are all important people. And besides that, the nurses, the resident doctors, everybody should participate, should emphasize on the value of quitting tobacco to such a person. And then it is more likely that he will be motivated more to stay quit.
So, doctor, should I take the questions from here on the chat box?
I have few more slides left.
Okay,
how much
done.
time do we have? I think, have we completed the time?
Yes, doctor, it's already 6. No problem, doctor. We'll continue with it.
Okay, I'll take few more minutes, 10 minutes or so.
Done.
And I'm going to talk thereafter if we have discussed the case little briefly, but I hope it helps people. Establishing tobacco cessation clinic. I just want to emphasize these points that it is easy to do that. It is cost effective than any other service. And it's a win-win business model for all the stakeholders, the hospital management, the administration, the patient, the doctor, everybody gets benefited, especially in the private sector. What is most important to begin with is to obtain the concurrence of the management and administrative support. The conduct is very important as to who is delivering the tobacco cessation, qualification and capabilities of the consultant, his commitment to help people stay quit, integration of systems approach in a health service of screening the people for tobacco use, treating them in time and then following up them regularly. And lastly, the data management and report. Data management is very important. If you don't have software, do it in the Excel sheet. Make the daily entries, schedule for the next follow-up, so that follow the assessments of the outcomes of these events, quarterly reports, not only for reporting to the administration, but also for the self-assessment and update to the peers for increasing reference. I'll skip this slide, just putting up all these factors to say that it is the motivation and ability of the hospital service and hospital policy which can make a difference in delivering tobacco treatment to the people. So, takeaways, it kept simple. It when used together, the height is always able to work through the system search. Everyone is managing data critical because by showing it helps thinking. This is way ahead for all the healthcare professionals, whether we wish to remain the part of the problem or its solution. For lesser morbidity and mortality burdens of the most and fatal tobacco-related non-communicable disease in India, I think we should start acting now by addressing the risk factor, tobacco first of all. Of course, obesity also requires to be addressed. Alcohol is another problem that is to be addressed. The lack of physical activity is a big problem, but tobacco treatment, dependence treatment is the way ahead. This is one exercise where the people have to fill up the blanks. The answer here is tobacco use is a disease and a tobacco user is a patient. Another exercise here is that quitting benefits regardless of the age. I am just quickly running over this slide. So this is my last slide, that tobacco cessation in the entire continent of tobacco control is the low-hanging fruit. It is the right time to grab it. Anybody can deliver tobacco cessation if you have learned the basics of delivering tobacco cessation through minimal intervention and the prescription of the drugs, and making people learn how to use drugs, how to use the skills to eliminate triggers, person, place, and time, so that a person becomes tobacco free and stays tobacco free. I thank everyone for the kind attention.